Welcome, everyone. This is one of the podcasts for the simultaneous publications for the Heart Rhythm Society meeting that's going to be in San Diego next week. It'll be at the time of the meeting when you get to see this recording. I'm very happy to have one of our advanced fellows, Dr. Mohamed Gabr, who's going to be presenting a vignette that we're publishing simultaneously with the meeting. And this is regarding a novel approach for phrenic nerve displacement using a fixed array multipolar mapping catheter during epicardial ablation. Mohamed, would you like to present the case for us, please?
Yes, thank you for the introduction, Dr. Tedrow. I'm happy to present this case that we found very interesting. But briefly, this is a case where we used our available tools to displace the phrenic nerve during epicardial ablation. This was a patient, a 62-year-old gentleman with a history of non-ischemic cardiomyopathy, had a prior VT ablation, who came in with VT storm, multiple ICD shocks. And for a little bit of context, he'd had a prior ablation about 8 months before that, an endocardial ablation targeting the basal anterolateral left ventricle and the AMC area as well. For those of you who can see the images in figure 1 here, this is the EKG that the morphology that he presented with. Very broad, large MDI, QSN1, and AVL as well. And from previous imaging he'd had in the past, a previous MRI had showed near circumferential delayed myocardial enhancement involving the basal to mid segments, predominantly an epicardial and mid-myocardial distribution. So our suspicion was high to begin with that we're dealing with an epicardial VT here. We obtained further imaging to help us with our planning. And for those who can see the images in figure 2 here, this is a cardiac CT with delayed iodine enhancement that was 3D processed using InHeart, and it revealed subepicardial iodine enhancement in the basal anteroseptal and basal anterior wall, just showing a scar here, basically the basal anterior area of the LV. We brought the patient to the EP lab and used the ventricular tachycardia with the morphology that we'd seen earlier. We performed voltage mapping that revealed this basal anterior scar on the epicardial surface, again seen here in image 3, and activation mapping as well when VT was induced that also revealed the circuit to be in that same region. So we merged the cardiac CT images with our electroanatomical map, and what we were able to see is that the phrenic nerve appeared to overlay our area of interest, which was seen here as well in figure 4. We did pace mapping, high output pacing from our catheter, which confirmed the same. The yellow dots here on that same image show the where we paced the phrenic nerve, sort of identical to the area seen on the CT. For our epicardial access, we actually had 2 Benson wires in the epicardial space. So at that point, we decided to put in another sheath. And what we used is we used the fixed array high density mapping catheter, a grid catheter, and decided to try to flex that against the epicardial surface to displace the epicardial nerve from the epicardial surface. In 5A here, we can see that in RAO and left lateral views with the grid catheter pushing against the epicardium. And to confirm that that was effective, we performed pace mapping. So our mapping catheter was against the epicardium, our ablation catheter on the epicardial surface where we wanted the targeted site was, and confirmed that we were not capturing from the epicardial surface with the ablation catheter, but we're capturing with the grid catheter. And with that, we were able to confirm that there's no capture on the surface. We're able to perform the ablation safely in 5B and 5C here. The red dots represent the lesions, the ablation lesions that were performed. They were performed effectively, safely, with no phrenic nerve damage. We confirmed that with pacing afterwards as well. And so this was a very interesting case for us, and we were glad that we had this outcome. I think the main advantages that to advocate for this strategy is just the stability that the grid catheter provides. And for this case, we didn't have to manipulate the grid catheter much. Basically for the duration of the ablation, we kept it in one stable position, didn't have to reposition it to continue our other lesions. And then it may be easier than other strategies such as air, saline, insufflation, or potentially the use of vascular catheters. So I think it's a good combo, a steerable catheter with the high density mapping catheter, the fixed array catheter.
Wonderful. Thanks for summarizing that. It's a really great case report and a wonderful presentation. And I don't have that much to add, but I would just point out that a number of years ago, there was a paper from Paolo Della Bella's group where they looked at these. There are a number of these non-ischemic scar patterns where the phrenic nerve winds up being in the way when we're epicardial. And they looked at cases where they just avoided the area where the phrenic nerve was present and didn't ablate, and versus ones where they had displaced the phrenic nerve and ablated in those areas, and there was higher success rate in those in whom the phrenic nerve was displaced. And as you mentioned, so you can use saline to displace the phrenic nerve. You can use different kinds of vascular balloons. Even a GI balloon has been reported before. The problem with those balloons is they often distort the anatomy a little bit. They displace your catheter a little bit. It can affect how you deliver your RF energy if you're delivering RF for your ablation. So the nice thing about this is it was very stable. We could actually still pace from the catheter. It actually, I think, enhanced the stability on the epicardial surface. So it was a really nice, simple adjunct to the procedure that enhanced the success rate. So thank you very much, Mohamed, and congratulations on the simultaneous publication. We look forward to seeing the poster at HRS.
Yes, thank you, Dr. Tedrow, and we'll see everyone at HRS.